Our next presentation will be given by Dr. Orefe Adeshina from UT Health in Houston, Texas.
Good morning. I want to thank the organizing committee for inviting me to speak this morning, and we will get into the case. Title of the case is I'm Having Trouble Driving. I have no financial interest to disclose. The patient is a 52-year-old man who noticed the onset of progressive peripheral vision changes about 7 months ago. He noticed that it was hard to drive. Looking to the sides was difficult, so he'd have to turn his head to try to see traffic moving by him. He saw an eye care provider, was found to have ocular findings suspicious for glaucoma, and therefore was started on drops despite having normal intraocular pressures. He was initially started on a prostaglandin analog, but his vision continued to deteriorate. He was put on a second drop to try to bring the pressures down even more, thinking that it was low-tension glaucoma. Despite this, he continued to have issues and referred for consideration of glaucoma surgery. When the glaucoma doctor saw the patient, he was then sent for neuro-ophthalmic evaluation. He has a past medical history of high cholesterol. He had LASIK in both eyes in 1998. He's on appropriate medications for his cholesterol, and he's on 2 ocular antihypertensives. On examination, he's 20/25 in the right eye and 20/30 in the left eye with some struggling. He has no APD, a slightly decreased color vision in the left eye with an otherwise normal eye movement examination and anterior segment examination. Here is optic nerves, and I'll ask the panel to comment on the appearance of these optic nerves.
I'm sort of surprised that he doesn't have an APD.
He has a tiltable pupil examination, but when you go back and forth, no APD.
So for me, when I'm trying to decide if it's glaucoma or not glaucoma, don't look at the donut hole. Look at the donut rim. So what we're looking for is rim pallor, because glaucomatous cupping and non-glaucomatous cupping look slightly different. If the cupping is up and down, that's kind of glaucoma cupping. If there's anything side to side, that's kind of like a special type of glaucoma called not glaucoma. In addition, clinically, we'd like to know if the acuity is down because the papillomacular bundle is in the center. So the acuity and the color, those are kind of late things. And 7 months, kind of fast, don't you think?
Mm-hmm. So what do you think? Do you think there's a little pallor in that rim on the left?
Yes, but machines can answer this question better than people. The most overcalled thing in my practice, temporal pallor.
Also in glaucoma, you very often will, instead of seeing the vessels being pushed towards the side, you'll have bayoneting of vessels actually over the rim and right into the cup to the center. And so this is not typical of that.
And we also heard that the color vision was down, right? Mm-hmm. Which would be atypical for early glaucoma.
Mm-hmm. The other thing is the absence of the RAPD. It doesn't mean there's no D. It could be no R. Relative to the other eye, it's bilateral and symmetric. So if you have no RAPD, it could be no R, no A, no P, or no D.
Right, but there's a significant asymmetry between the right and left disc.
So in my practice, the most common cause is no D. No defect was detected by the resident who swung the light, but no R could also explain the problem here.
We're going to have a poll to see how many times Andy Lee's going to say no in this session.
No, we're not.
All right, so we had our discussion. The next slide will show the OCT.
The machine sees it better than you. Rim pallor.
Yep.
Papillomacular bundle dropout, correlating with the loss of acuity and the loss of the color. Not glaucoma.
So is he really a drinker and not admitting it?
He denied drinking. Didn't ask him any more pressing questions, but he did not. He said that he did not drink.
Ask him again, just in case.
And here is the visual field.
Yeah, yeah. And if you go back to the OCT, by the way, we talked about the left, but on the right there's some thinning of the papillomacular bundle as well.
Mm-hmm.
So this is his.
Right, yeah.
This is worrisome. This is not glaucoma.
First of all, we should point out that we're putting the fields up like the neuro-ophthalmologists look at fields, not the way glaucoma docs look at fields, which would be the other direction, and this would look like binasal defect. This is a bitemporal defect.
But it's a bitemporal plus, so
Yes.
it's not solely a bitemporal defect.
Correct.
And so that's extremely localizing in where you're getting compression.
Yes.
So glaucoma respect horizontal meridian because the nerve fiber layer does that, not the vertical meridian. Glaucoma nasal field because temporal fiber, that means the cupping is up and down, not side to side. Temporal field, hemianopic, not glaucoma.
What are your
NOAG.
What are your thoughts on what this potentially could be?
That'd be called a tumor.
Yeah.
So when you commented on the localization, Dr. Gordon, where specifically are you suggesting?
Well, so you have the bitemporal cut, so you know that it's chiasmal, but it's chiasmal plus. This is called a junctional visual field defect. It tells you that it's pressing on the chiasm, and in addition, it's pressing on the nerve anterior to the chiasm, causing that infranasal defect as well. So it tells you exactly where it is, and it tells you exactly what to tell the neuroradiologist. And he goes directly to neuroimaging.
So, our audience response question.
Oh, no.
You gave away the answer.
I'm sorry.
When is the answer not MRI? If anyone gets this.
He might have glaucoma too.
We should have done this.
Well, it could be a different kind of consent, right? All right.
All right, looks good. So this is his MRI with contrast. Can the panelists comment on what they see on this MRI scan?
So the slide on the side, the image on the right side is a normal MRI for the audience.
Yeah, it's normal.
Oh.
The patient's
The patient's MRI
patient's
is on the
scanning.
left.
The patient's scan on
Say
your left.
post-op imaging is shown on the right.
Sorry. So this is the patient scan, which is on
That good.
No.
the left.
Good job, guys.
And this is a normal scan in comparison on the right.
His chiasm on the left image clearly looks more like a saddle than a straight line, implying that it's being pushed up centrally. Instead of seeing an enhancing mass, we're seeing sort of a black space or what could be a cystic structure. Otherwise, the brain looks pretty normal.
So the top four things in adults in this location would be meningioma, pituitary adenoma, craniopharyngioma. If you're younger adult, dysgerminoma or suprasellar aneurysm. The imaging characteristics suggest cystic adenoma versus Rathke's cleft cyst or cystic predominantly craniopharyngioma, but the lack of the solid component suggests cystic pituitary adenoma.
I agree, and that's what we thought it was. He did undergo resection of the tumor the next month, and it proved to be an epidermoid cyst. Postoperatively,
Do you have the DWI? Because the DWI would have been helpful in differentiating those things.
I don't have it here, but it did show some characteristics of restriction consistent with an epidermoid cyst.
Yeah, so we always look at that DWI. If it had shown the restricted diffusion, we would say, oh, that's more likely to be epidermoid cyst. The only reason it matters is we don't want to be spilling the stuff out into your brain if it's epidermoid cyst.
Cause a lot of inflammation, definitely.
It's another reason you really have to look at your own scans, because a lot of people, they'll see a black void and sort of say, oh, there's nothing there, instead of realizing that depending on the different sequences, there's a mass.
So these are his pre-op fields again. Postoperatively, fields improved significantly. However, in the left eye, on the pattern deviation, there are still some notable visual field changes. Any comments on the visual fields?
Glaucoma.
No, great result from the surgery.
And glaucoma.
And there's another comment from the audience at this point. You know, you showed the MRI and we saw the bowing of the chiasm, and yet there's still recovery. At what point do we say that this is too big to get recovery, or is there a size of a lesion that denotes that recovery won't occur after surgery? Or what are some of the prognostic factors that occur when you're first seeing a patient prior to surgery that you could talk to about the patient regarding recovery?
So duration, the guy was only 7 months. The shorter time period, the more likely to recover. Optic atrophy, that's kind of a bad thing. Red zone on the OCT and green zone on the OCT. So the one that completely recovered, green zone, green good. Other eye, a little bit of red zone, I would say. Mostly green, a little bit of red. You're probably going to get everything back on the green eye. Might have a little deficit in the red eye.
Which, you know, in essence, when we looked at the photos of the optic nerves, we already, you know, knew that there was an issue with the left eye. And so you can see the amount of recovery that he had, but not complete recovery. That's not surprising. I agree that the OCT can help you tremendously, especially the retinal nerve fiber layer preoperatively. But I would say never unless the retinal nerve fiber layer is sort of gone. These patients can surprise you. And the best thing that you can do for the patient is to get them to a great neurosurgeon. And then follow the patient carefully afterwards. Don't give patients false expectation of recovery or lack thereof based on anything that we see, because if you practice this long enough, patients will surprise you.
I also do the macular ganglion cell for this kind of patient too, because you can't rely on that nerve fiber layer thing sometimes. So macular ganglion cell to me is be a better predictor of recovery.
Yeah, but I've seen macular ganglion cell layers stay in the red zone with pretty good recovery of visual acuity as well, so there can be a disconnect there too.
I agree. There's a big difference between dead and mostly dead.
Well, and
Mostly dead is still a little alive.
I have seen masses, 5 times that size, lifting the chiasm up, splaying it sort of like a squirrel suit, and recovering to 20/20. What you have to be sympathetic about is the patient still claims that their vision's not good, so it's very dirty or less clear 20/20 vision, but they can get it back even with significant damage.
I use it not just for prognosis, though, because if the patient doesn't recover, I'm going to re-image the person. I might call up neurosurgery and say, hey, did you guys really get a gross total here? Because I don't think so.
And Dr. Lee said earlier was the one on the right post-op. And, I think we would all agree here, nobody looks that good post-op.
Dr. Lee, you mentioned the most important thing, or one of the most important things is to send the patient to neurosurgery. Does the general ophthalmologist seeing this patient that hasn't had any exposure to any of the doctors have a responsibility to order a prolactin level, a thyroid level, a GnRH level, or send a patient to an endocrinologist, or is somebody else supposed to do that?
I think that the ophthalmologist shouldn't have to do that. I think the neurosurgeon that's going to be involved should be doing that, or perhaps the neuroophthalmologist and the endocrinologist. So I don't think that's the ophthalmologist's job. Diagnose the tumor and move it along to the neurosurgeon. And I think what Lynn said is crucial. She said a great neurosurgeon, because neurosurgeons who also do lumbar spine surgery and aneurysms and this are not going to be as good as neurosurgeons who do this all day, every day. You want a brain tumor neurosurgeon.
Thank you very much. So final diagnosis is compressive optic neuropathy from supracellular epidermoid cyst. Optic nerve cupping is most commonly seen with glaucoma, but as we know, there are other causes because it can be a nonspecific sign of axonal loss and ganglion cell injury. Things to look for are pallor, like the panelist said, fields that are atypical for glaucoma, asymmetric cupping, and an RAPD. Thank you.
Thank you very much.